Hello, everyone, and welcome to the Learning Lab event on Prediabetes Care Pathways to connect patients with community support. If we haven't met yet, my name is Emily Noodleman, and I'm the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the Bree Collaborative program in the implementation of the reports into practice, and I also support the Foundation's Health Equity work. We are all very excited to have each of you join us today, along with our speakers, as we engage together in this event and explore how our healthcare ecosystem can support patients at risk for developing diabetes. We want to welcome you to the event and just review a couple housekeeping items as we get started. First, please take a moment to ensure your first and last name and any credentials you may have appear in your username on Zoom. This is really helpful for us so we can take attendance for the event. During the event, if you do have any questions you'd like to ask our panelists, please place them in the chat box located at the bottom of your screen, and we will try to ask them to our speakers during the Q&A portion of our presentation. Also, if you could please ensure you're on mute to minimize disruptions as our speakers present, that is immensely helpful. And this event is being recorded and will be accessible on our website after the event. If you did sign up for today's event, we will also send out a PDF copy of the slides. For our disclosure, no one in control of content has indicated a relevant financial relationship with an ACCME-defined ineligible company, also known as commercial interest. All clinical content presented will be evidence-based and unbiased. The Learning Lab event has been approved by WISMA for individuals to attain CME credits. The CME credits are available to claim for individuals who are attending the live event only. Unfortunately, we're unable to provide CME credits for individuals who watch the recording. To receive the CME credits, please complete the post-webinar survey, which will be linked at the end of this event and also emailed out. The agenda for today's event is to provide a short introduction to the Bree Collaborative. Then we'll have the opportunity to hear from our speakers, followed by a panelist discussion where we can pose those questions to our speakers. And then we'll have some time where we'll transition to engage with peers in small groups to meet people from across the state and really hear what's going on within their area and within their organizations. And finally, we'll come back as a large group to wrap up and close the event. The learning objectives for our learning labs are to identify how a Bree or Foundation for Healthcare Quality guideline can be implemented into practice, recognize how social drivers of health can impact a person's overall health status, plan or modify strategies to center health equity into quality improvement initiatives, and engage with peers working throughout the healthcare ecosystem who are in attendance today. We want to provide a brief introduction to the Bree Collaborative, which the Bree was developed in 2011 by the Washington State legislation so that public and private healthcare stakeholders would have the opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability in Washington State. These stakeholders are appointed by the governor as collaborative members and represented different sectors of our healthcare ecosystem, such as hospitals, clinicians, health plans, purchasers, among many others. Each year, our members identify a healthcare service with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. Once a topic is identified and chosen as a focus for the next year, the Bree Collaborative forms a work group of subject matter experts to develop a report that provides information and guidelines for actions different audiences can take within the healthcare ecosystem to improve care for that topic. For example, in 2023, the Bree facilitated a work group on diabetes care and developed a report that was published January of this year. Our reports provide more knowledge on what is to be done to support patients on that certain topic, like diabetes care, but we still want to recognize that it can be hard to know how to implement a guideline, which the Bree defines as an action to be taken to improve healthcare for a specific healthcare service. In today's webinar, our goal is to show you how some of these guidelines and information described in our report, like refer patients at high risk for diabetes to a National Diabetes Prevention Program, or a DPP, or special diabetes programs for Indians, and how healthcare delivery systems are recommended to create workflows, protocols, procedures that reflect up-to-date evidence-based clinical practice. The work group identified resources to support the development of these protocols. For example, a clinical care pathway, which we'll hear more about today from Valley Medical. Our speakers for today's event are Whitney from Valley Medical and Sally Lacey from the YMCA. We'll have the opportunity to hear how they work together to develop this pathway and connecting patients to the YMCA to receive that diabetes prevention program. So I'll pass it off to them.
Great. I'll get us started. Thanks so much, Emily. I'm Sally Sundar. I oversee all of our chronic disease prevention and management programs for the YMCA of Greater Seattle and support that work across the state of Washington through the Washington State Alliance of YMCAs. In that role, I oversee all of our clinical partnerships and the referral pathways from clinical care to the Y to get patients connected to evidence-based programs in the community that support lifestyle change and are associated with specific diagnoses like prediabetes. Just as some context, we have been providing the Diabetes Prevention Program, or the DPP, which I'll be calling it by shorthand today, for over a decade, and we have been a CDC-recognized provider of the program and a Medicare supplier of the program under CMS since 2018. So we'll be providing the Y and Valley Medical Center today will be sharing some best practices about how a clinical system and a community partner like the Y can partner to make some of these recommendations in this report come to life. And again, just as some background context, a lot of the things that we worked on together and some of the best practices that we've discovered together were done through a multi-year project funded by the American College of Preventative Medicine and American Medical Association that helped provide some of the structure and evaluation of the different efforts we engaged in to land on some of these best practices around the DPP referral. Next slide. Okay, so the report from the Bree Collaborative Diabetes Work Group outlined a number of recommendations intended to reduce the burden of diabetes in Washington State. And as we know, these recommendations are only meaningful if the stakeholders that they target can find ways to bring them to life and make them effective in our actual day-to-day jobs. So I've called out a few of these recommendations here and hope to give some really concrete examples that stakeholders on the call today can act upon now or in the near future. I'll be focusing a lot on the DPP, or prevention of diabetes, but a lot of the workflows and approaches that we discussed today can be applied to diabetes self-management and other lifestyle change programs that are relevant to this space. So if you want to press the animation, I've kind of summarized 3 of these key recommendations into what I'm calling build it, use it, and support it. It being the referral pathway from the clinical setting to the community setting for the DPP. The foundation of any successful clinical community partnership is having an effective handoff in place from clinical care to the community setting, or the community care setting, as I like to call it. And so that starts with building a successful and effective referral process. And we'll be talking today about what that looks like in Epic at Valley Medical Center. But it's not as simple as just building it. If you build it, they will come is the hope, but you have to really create reasons for the providers to be aware of this referral pathway and to feel motivated to connect their patients to a resource like the DPP. So we'll be sharing a number of ways that we would promote the use of the referral by the providers and even the patients who can advocate for that referral to be made. And lastly, when a patient's referred to something like the DPP, a year-long healthy behavior change intervention, they need to have as many reasons as possible to say yes, and as few reasons as possible to say no. So we'll be sharing some ways to support the uptake of that referral, including primarily making sure that there's insurance coverage in place. Medicare nationally covers the DPP with no cost sharing to the member, and we really want to be able to say the same for Medicaid and other types of payers. Next slide. So you can click it one more time, diving deeper into each of those topics, what it means to build an effective e-referral pathway that will actually get used. There's a screenshot here out of Epic of what that looks like. And that, first of all, we're talking about building a referral into the EHR or EMR that does not require a healthcare team member to leave their existing workflows to make this referral. When it's the referral order to the YMCA is directly built into Epic or whatever EMR that you use, it's really simple and seamless to make that referral for that patient while you're with them, or in whatever way that it's the referral is being made after the fact. That's more effective than handing the patient a brochure or a flyer and saying, hey, this program might be a good fit for you. You should call the YMCA. We know that uptake is a lot lower in those cases versus when that referral is made directly to the Y, and we can do that outreach and really get that person connected to a program that's going to work for them. This also allows the referral to be populated into the after visit summary, which serves as a reminder for the patient that they had this conversation with their provider. I do want to call out making sure that the provider has a conversation about the referral and doesn't just make the referral, after the fact, thinking, hey, maybe they'll like this program. But really, while they're talking to the patient, saying, this is a program that I think would be a good fit for you, and here's why. And then having the AVS really serve as a reminder of what that program entails, and even including contact information that the patient can use to call the Y themselves. Sometimes we have patients who are really ready to get started, and we want them to be able to do that as quickly as possible. And they might even call us before we've had a chance to call them. You can use smart phrases built into the referral order that give really clear talking points to the referring provider team that make sure that they have accurate talking points that they can remember about what the DPP is and what its goals are when they're sharing that with the patient. You can also consider some best practice alerts that do things like flag somebody's A1C level or other indication of prediabetes to make sure that you remember to call out the fact that maybe it's a new or an ongoing diagnosis of prediabetes and have the opportunity to make that referral. I always say, don't say no for the patient. You never know who really would want an opportunity like this, and for whom this type of relationship-based, community-based program might be just the thing that they need for a lot of aspects of their health and well-being, not just the fact that they want to address prediabetes and avoid a diagnosis of diabetes. So making sure that you give the option as much as possible. There you go. So also promoting use of the referral. We work with essentially every health system in King County and many around the state. We have these referral pathways to the Y, DPP, and other programs built into those systems. But by far, Valley Medical Center is the highest referring system. And I think it's because, as you'll hear about, they built a concrete care pathway around prediabetes and then implemented a number of quality improvement initiatives that held their providers accountable for increasing screening and referrals related to prediabetes. And I really feel like that system-wide integration or system-wide approach around this work is the key difference in why we see so many more referrals from Valley Medical Center, even though we work with systems that are arguably larger and dealing with larger patient populations. Next slide. Okay, you can feel free to press one of the animations there, Emily, thank you. So supporting uptake of the referral, again, we want the patient or the person to have as many reasons to say yes and as few reasons to say no to doing something like a year-long intensive health behavior change intervention, which is what the DPP is. If it was easy, we wouldn't have such a high need for something like the DPP. We know that 1 in 3 adults are estimated to have prediabetes and would be eligible for this program in the US. So one of the key approaches to that is making sure that we have coverage. Medicare covers the program, and it's pretty easy for me to get our referring providers to make referrals for their Medicare patients because they know it will be covered, no cost sharing. It's going to be really simple for them to enroll. That's not the case necessarily for other payer types. The YMCA and the Healthcare Authority and Molina Healthcare have been participating in a 2-year pilot around Medicaid coverage of the DPP. It's absolutely true that the Medicaid population faces more barriers to engaging in a lifestyle intervention, but they are absolutely saying yes to enrolling in this program. Anecdotally, I can share that a lot of the Medicaid individuals that we talk to are sometimes shocked and really grateful that this type of program is being offered to them. And we're hearing things like, no one's ever really asked about my day-to-day life and what it means why I struggle to stay healthy in the way that I want to. So a program like this really is a game changer for that population. We'll continue expanding that pilot this coming year to more Apple Health plans in Washington. We also want commercial plans and really anyone who can offer that coverage to their member to increase. We also know that co-branded flyers and things that bring the clinical kind of stamp of approval and visibility to the program go a long way in lending credibility to a community-based, evidence-based program like the DPP. When the patient sees UW Medicine, Valley Medical Center logo on the materials that they're looking at, whether that's in the waiting room or on the website or their provider is handing it to them during their visit, it goes a long way. And it also helps the provider feel confident that their health system stands behind this intervention and is supporting access to it for their patients. And then one more click. Making sure that the provider or somebody trusted on the care team, that could be a community health worker or a health educator, whoever it is the one presenting this program opportunity to the patient. We have a lot of people who tell us, I really never saw myself doing a program like this, but my provider said I should think about it. And, I trust them. I want to follow through on that. And that can be a one-on-one conversation that happens during an office visit, perhaps in response to a new diagnosis of prediabetes or even one that's been there for years. But it can also be through something like a mass MyChart message where you can target a lot of people who would be eligible at once and give them the chance to opt in to that provider who can then send the referral on their behalf. We find that to be a really efficient way to get more people connected outside of just relying on point of care conversations. Next slide. So this is just some data to give a sense of how all of the efforts we've engaged in with Valley Medical Center over the years have led to a really successful, sustainable stream of referrals. On the left, you can see some of our top referring health systems in 2023 to the YMCA of Greater Seattle. Valley Medical Center refers by far the most patients to the Y. They also have the most individual referring providers. And again, some of these health systems that we work with actually have more locations and more patients, but we're seeing that the efforts we've made with Valley Medical Center have really led to sustained high referrals. On the right, you can see the 5-year span in which we participated in the American College of Preventive Medicine sponsored project with Valley Medical Center. And in 2019, the referrals were fairly low, about 100 per year. And that started increasing over the course of the project when we implemented some of the PDSA quality improvement work that Lindsey will share. In 2021, the referrals really spiked. We had the most we've ever had. And even though those tapered down again a bit after some of those really acute efforts were over, they have remained high over the even as the project ended. And so I think that really speaks to the fact that it can take some work to integrate some of these clinic to community workflows and provider awareness efforts, but the fruits of those labors are sustained. So with that, I will hand it to Lindsey.
Thanks, Sally. So I'm going to kind of just speak to some of those things that Sally talked about and how we did them at Valley Medical Center. And that way, just kind of give some more concrete examples of the interventions that she was talking about. Sally just kind of referenced this, but the timeline that you see at the bottom, this is kind of the active part of that project that we were doing. And I wanted to share this to sort of emphasize that as I'm talking about these interventions and these things that we did, it wasn't an overnight change. It wasn't something that we did over the course of a couple of weeks and all of a sudden we had all of our providers referring. This work took several years. I say that with the caveat that it's not like this is the only thing we were doing over those several years. There was lots of other projects and priorities and initiatives happening, also COVID happening. But just doing small incremental tests and changes and updates and new tools and focusing on this work kind of slowly over time is really what helped us build this sort of sustained model now where we have these workflows more hardwired. We can go ahead and go to the next slide. So one of the things we did really early on that I think laid kind of the strongest foundation for this was really developing that strong partnership between Valley and YMCA. This was the first time that we had worked really closely on referring to a community organization. And so making sure that we had very clear lines of communication and ways that we communicated back and forth about things that were happening with the work and with the project. That looked a lot like making sure everyone at Valley that was working on this knew who to call and who to contact at YMCA. We had a lot of shared documents, so things like referral trackers, tracking cohort outcomes. We both had access to the same documents and were updating the same tools. So that way, if there was questions or people needed to know where we were at with something, it would be really easily accessed on both sides. We also had a lot of meetings to kind of direct this work. So we had quarterly steering committee meetings, which had more of our leadership and all of our participants from both orgs that were working on this project to kind of make sure that we were all aware of what was happening, that we were keeping this as a priority, really moving the work in the same direction. And then we had monthly meetings that were more just those of us focusing on the actual project work. That was really a good opportunity to brainstorm new things that we could try to address problems and issues that were coming up. I think anytime you're working with an outside organization, it's important to have sort of that avenue for discussing things that might be coming up, so that we have an opportunity to fix them and address them as they're happening. And then one of the things that I think ended up being really cool was we had joint participation in training. So anytime a training was offered related to DPP around marketing for DPP or just helping patients enroll in the program, we had someone from Valley and someone from YMCA attend. It really helped with making sure that we were sort of speaking the same language and talking about the same things as the project moved forward. So we weren't trying to like catch up with trainings at the same time. We can go to the next slide. So as Sally kind of talked about, and part of the diabetes report from the Bree Collaborative is really to develop a workflow and a care pathway around doing this work. I will say that at Valley, we have a pretty robust ambulatory care pathway program. This is how we develop our workflows for a lot of different diseases right now. So we already had a lot of buy-in support behind care pathways. If you don't already have a care pathway program or you're, working with a healthcare organization that doesn't have care pathways, prediabetes is a really great place to start because it's a pretty straightforward workflow. There's really clear guidance on who we should be screening and how we should be doing that, and what we should be doing for those patients. So I am going to share with you what our care pathway looks like, just so you can get an idea of the workflow we created. But in order to create that workflow, we did have to make sure within Valley, we also had our subject matter experts, representation from the roles that would be involved in providing this care, get together and really talk through what our workflow should look like, understanding what was already happening at Valley for prediabetes care, and then also evidence-based practice, current literature to make sure that whatever workflow we developed was the best practice for our patients. Then we can go to the next slide. So this first algorithm I'm going to show you, so I'm going to share two different algorithms with you. We have it separated because we have a whole set of diabetes pathways as well. And so we have combined our prediabetes and diabetes care algorithms together. And so this first one is screening, and it's meant to define which patients are we looking at for screening for prediabetes and diabetes. And then based on those results, what should you do next? A lot of the purpose behind this one is to make it really clear the population that we're talking about. Evidence-based practice guidelines change and the population of who should be screened changes. And so we want to make sure that our providers and staff have very clear guidance on that. And then also what screenings are we asking them to do and what does those results mean? This one branches out into 3 different categories. So you can have a patient who's negative for screening. You're gonna have a patient who's positive for prediabetes or positive for diabetes. Obviously, we're talking about prediabetes today. So if a patient screens positive for prediabetes, this then directs that provider to the prediabetes ambulatory care pathway. And we can go to the next slide. So the prediabetes care pathway, like I said, this is a pretty straightforward workflow. The first thing that we ask the provider to do is add prediabetes to the problem list. So identify that that patient has that condition. Part of why we do that is because we have a lot of tools built into our electronic medical record. And so identifying the patient has prediabetes allows some of those tools to automatically work in the background. And then the first step that we ask the providers to do after identifying prediabetes is to use shared decision-making to discuss DPP with the patient. That is our first line intervention. That is what we recommend for every patient above and beyond any other interventions, because we really think that DPP is the best intervention that we can give for our patients. By building it into our pathway like this and setting that precedence for our providers, it also kind of establishes that expectation that every single patient should have a conversation at least about DPP. Sally kind of talked about some of this, but a lot of how we try to make sure that the workflow is really being utilized is building tools into the EMR to support the steps that we're asking them to do. So we do have a smart phrase that has standard education about what is prediabetes, what is DPP and why is it important. We have an educational flyer that is co-branded and built into our EMR, so it can be added to an after visit summary or sent to a patient via MyChart, or it can be printed out and given to the patient in a paper format. So just making those tools very accessible and easy to utilize within the electronic system. Next slide. And then this pathway, after we have that shared decision-making conversation about DPP, the next step is whether or not that patient agrees for the referral. If they do agree to the referral, the next step is to order that DPP referral. And again, as Sally talked about, our referral is built into our EMR. And it's meant to be as easy as possible for the provider. So once they sign the order, everything that needs to happen after that happens automatically. So that means the referral is automatically faxed to the YMCA with all of the necessary information for them to be able to contact the patient and enroll them. There's also education that the patient gets about DPP and what that means. At Valley now, we didn't when we started this project, but now we actually have an internal DPP program as well. So we give patient information about what those two DPP programs look like. I will tell you that we refer to YMCA a lot more often than our own program because of the locations. Our hospital system covers patients across all of South King County, and we have primary care clinics in all of South King County. So in order to reach all of those patients, it's actually usually easier for us to refer them to YMCA because the YMCA locations are closer to their homes. But we give the patient the information and allow them to kind of make the choice. And then we do also have, if a patient does not want to do DPP, or maybe they want some more time to think about it, there are some other interventions we can do. So we have a smart set or an order set available for our providers to use to really easily order those things, those other interventions they might need, just to try and make everything kind of built in and really simple, as little steps and clicks as possible for our providers to do. Next slide. So we built this pathway, and like I said, we have a pretty strong care pathway program already, but we also know that just because we put it together doesn't mean people are going to use it actively or really be able to hardwire it right away. And so we have a quality improvement committee for our clinic network that does PDSA projects, or small tests of change, to try and really hardwire different workflows for different projects. In this case, we did a PDSA project around improving implementation of that prediabetes care pathway. So the goal was to improve by 5% each of these three categories. So the percentage of patients that were screened, the percentage of patients that were actually had prediabetes added to their problem list, so sort of identified, and then those that were referred to DPP as sort of our primary intervention. Over the course of this 3-month project that we did, we give the clinics the opportunity to try and come up with their own ideas and ways of how they might improve this work, hardwire these workflows. But overall, we saw a 7.5% increase, kind of average across the clinic network of percentage of patients screened and diagnosed. And we saw the number of referrals to DPP more than double. That's that graph that Sally showed where there was that big spike in 2021. That was directly related to this PDSA project because we were actively giving the clinics an opportunity to focus on this work and identify what really hardwired that. And as Sally mentioned, even after the project finished, we still saw sustained increase in referrals and screening for prediabetes. I'm not going to talk too much about the strategies, but I will tell you it really boiled down to awareness, making sure that, we knew which patients were coming in that were due for screening and which patients had already been screened that needed some sort of intervention. Next slide. The last thing I want to talk about is education. So during this project, we did kind of a qualitative study to understand what were the barriers for patients enrolling. We knew, we had worked a lot on increasing screening and referral, but we wanted to make sure that just because we were referring patients that they were actually enrolling and that we weren't missing some barrier to that. And what we identified as sort of the number one issue was really around education. There was a lack of understanding for staff and providers about what DPP was because they hadn't experienced it. And that sort of led to a lack of understanding for the patient on what this program was, why they were being referred. And so we, towards the later part of our project, focused a lot on educating staff, providers, and patients. Some of the ways that we did that include really making sure that everyone is aware of what this is. So when we implemented the project, when we implemented any changes, new tools, new resources, we made sure to communicate that not just to our providers, but to all of the staff at the clinics. That meant MAs, RNs, managers, making sure that everyone that might be involved in this was aware of the changes that were happening. Also, we have some internal newsletters that go to staff and providers, so making sure we had articles published there with updates and periodic reminders of this work. And then we also collaborated with our marketing team to develop a staff education video. So this was a video that really went more in detail about what prediabetes is, what DPP is. It included a patient testimonial, so giving staff some access to understand what it's like from the patient perspective so that they could better and more easily talk to a patient about this opportunity. Next slide. And then we also focused on patient education. So Sally talked about this a bit with co-branded materials. We made sure that anything that we gave to the patient was very clearly from Valley and from YMCA to make it really clear that, we're working together. We're not just sending you to some other group. We don't know what's happening over there. We want you to know that this is our trusted partner and this is who we really want you to work with. We did a lot of posters and social media posts about prediabetes and increasing awareness and what DPP is and why that's important. When we referred patients, we also gave them information about YMCA's information session, so they knew when they could go to the information session and get more knowledge about the program. And then we did a similar video for our patients in that we call them doc talks, but they're basically, we have one of our providers do an educational video speaking to the patient perspective about here's this program, here's why I enroll my patients, here's why I think it's important, just some stuff like that. And then again, all of this education, anything that we built, we also made sure that it was available in our electronic medical record so that providers could very easily give it to patients if they use MyChart or if that was an easier option for those patients. And I think now I'm going to hand it back to Sally to kind of wrap us up.
Yeah, thank you. So this is just a snapshot of some of the outcome data. This is a bit outdated at this point, but multi-year outcome data for the DPP from the YMCA. I'm showing that because we often get asked by referring providers and their respective healthcare systems how we can send information back to the referring provider. Unfortunately, we can't talk to Epic. We can't easily say, we got your referral, they enrolled, here's how they're doing. That is the dream in one way or another. But we do track all of the information about the patient's experience through the referral workflow. Did they enroll? If not, why not? Where are they in the enrollment process? And then once they enroll, what is their attendance and weight loss and physical activity minutes and food tracking and other things relevant to the program? What does that look like? We do additional pre and post surveys as well. So we do share outcome data at an aggregate level with our referring healthcare system partners. And upon request, we do share patient-specific outcome data or information about if they enrolled or not. And hopefully, as our interoperability prospects increase in the future, we'll be able to give even more information back to providers. Next slide. So this last slide just summarizes all of the some of the main best practices we've landed on through this work with Valley Medical Center over the last few years. I realized I should have had a first bullet be build the referral pathway into the EMR. That in and of itself is a huge way to increase providers' access to the referral, awareness of the referral, and use of the referral, just because it makes it such a simple and seamless process for them. And making sure that the provider or whoever's making the referral actually discusses it with the patient. That is something that you would be surprised. A lot of the how many referrals we get that patients aren't aware that it was happening and don't really understand or know what the DPP is. And so again, just making sure that the introduction to this piece of their care pathway is done while they're talking in some form to their healthcare team, so that they really understand that the DPP is not just some random thing they might want to consider out in the community, but it's truly a part of their care pathway that their provider wants them to engage in. Then, of course, having the integration of the referral into the after visit summary, making sure the patient knows how to contact the YMCA directly should they want to, providing those co-branded brochures or flyers that are in the clinical space. We've had partners make posters in waiting rooms or exam rooms, or having the brochures available in different spaces. Making sure that your providers and healthcare team members don't feel responsible for answering every question about the DPP to the patient. They don't need to know when the next class is starting, or where, or how much it will cost, or if their insurance covers it. I can speak for the Y. There are other organizations that provide the DPP across the state, but at the Y, we'll have all those conversations with them. We make sure that cost is never a barrier for those that aren't covered by insurance. If they need to pay out of pocket and cost is a barrier, we make sure that that's not the reason they don't join, that we find something that works for them. Somebody might think they want to do the program in person and then find out that there's a virtual option that fits their schedule perfectly, and it's easier for them because they don't need to get childcare, or who knows. But just making sure that we get the chance to have that conversation through our trained health coaches so they can really find the best option for that patient. Relying on
just so you know.
Okay. Relying on both a reactive and proactive outreach to patients. Reactive in the sense that if they show up for an office visit and it's clear that this would be a program that would benefit them, taking the opportunity to talk about it and make that referral, but also proactive through MyChart, text, email, phone calls. We've seen a lot of sort of campaigns or different strategies happen with our clinical partners that reach people who are not necessarily coming in. And then really making sure that patients have the tools they need to refer themselves. We can get the information we need about their eligibility for the program after the fact if we need to, but a lot of patients who enroll are also those that self-refer, and they don't need to come through their doctor or another healthcare team member to get involved in the program. And lastly, just repeatedly engaging referring providers. We all know that, especially primary care providers, they have a ton on their plate. They're responsible for remembering many different things during every patient visit. So it's helpful to just re-engage them about this program, both the YMCA coming in and doing presentations or lunch meetings or whatever it is with providers on a regular basis, but also internally making sure that the system itself, like Lindsey shared, has ways that they get that information in front of providers on a consistent basis so that they are going to be more likely to think of this when they're dealing with a patient with prediabetes. That should be it.
Thank you so much. We will now transition to the Q&A with our speakers. As we do that, there was a handful of questions that came in the chat, and I just wanted to have the opportunity to highlight it here. One of the questions was just talking about how not every organization already has that pathway design within their EMR, which you were describing as a great first area to focus on when they're doing this. Could you describe a little more on, if they don't have that developed quite yet, what ways can they get connected and refer patients?
Yeah, so again, speaking for the Y, we have a secure fax form that anyone can use at any system. And I'm happy to share that. It can be used statewide, and it's just lands in our secure electronic fax inbox. So that's an easy way to make referrals. We also have a centralized email inbox that people can use. And then individuals who want to self-refer can do that through our email or through our website or phone number. We do call out that if you want to send an email, just making sure it's encrypted if it includes patient health information. But yes, there are options outside of just building the referral pathway. That may be a goal down the line, but you want to make referrals in the meantime, and there's ways to do so.
Could you also explain a little bit about the Medicare benefits versus Medicaid eligibility to register into the DPP program? And what is the experience with the populations 18 years or older trying to get into the program without Medicare or Medicaid benefits?
Yeah, so it is a federally required benefit under Medicare. So it's really easy with Medicare. Any Medicare Advantage plan is required to cover it. Some make it a little more difficult than others, but in general, we can almost guarantee that anyone with any kind of Medicare coverage is going to be able to access the program at no cost. For Medicaid, we have only been able to offer that in Washington through our pilot work the last 2 years in partnership with Molina, but we do plan to expand that to additional Medicaid plans in the very near future through ongoing work we're doing with the Healthcare Authority and Department of Health. And so we hope to have more to share about that soon. If you're asking about sort of challenges for adults under Medicaid enrolling in the program, it is a lifestyle change intervention. It's not simple to engage in a year of health behavior change. If it was, people wouldn't need it. So we know that there's, work schedule challenges and childcare challenges and just income challenges that make it hard to change some of the things you're doing around what foods you shop for and how you eat and prepare them. We do have care navigators, essentially social workers on staff that support people in addressing some of those things during the course of enrollment or engagement in the DPP. But in general, we see that while some people in the Medicaid space have difficulty opting into this intervention, like some of those challenges are just too difficult to say yes at this time, there is as much interest and motivation to do something like this as we see in other populations.
Thank you. There's a question about talking about your partnership together. Who initiated this partnership, and what suggestions do you have for other organizations looking for similar partners, either being a community-based organization or a group that's offering DPP and want to connect with the clinic system, or a clinic system who's trying to find someone out there doing a DPP?
Yeah. So the Y of Greater Seattle started doing this electronic referral pathway work in 2015, maybe with, at the time, Virginia Mason, among others. And as we found a lot of success and engagement there, we brought that to other partners that we had relationships with, like Swedish and UW. For this specific project, I saw the opportunity to apply for this ACPM funding. It was, to be transparent, not a lot of money. It was more just the level of support that we got from helpful partners like the ACPM and AMA and others in setting all of this up. So I went to VMC and said, I wrote an application, will you apply with us? And they said yes, and we got the right people involved. And, Lindsey and her team have been instrumental in integrating the this work into the workflows and ways that their providers think about options for their patients who have prediabetes or other conditions. So I would say that it's a both and. I mean, we might have initiated the engagement in this project, but they really went all in from the Valley Medical Center side and making sure that it would be successful in the way things work there. I don't know, Lindsey, if you want to add to that.
Yeah, I think the only thing I want to add is just that what we've learned through this work is how important and how beneficial it can be to have a really strong relationship with a community partner, especially when it comes to being able to offer an intervention and a program to a patient that we may not have been able to offer before. Like I said, we did not have our own DPP when we started this work. And even today, YMCA offers a lot of programs that we just don't have. So we're actually in the process right now of figuring out how to expand what we did with prediabetes to all of our other disease management care pathways, to really strengthen how we refer to YMCA. So again, I think, if you don't have a relationship with a community partner for something like this right now, DPP is a great place to start. And finding who in your community offers DPP and just reaching out to them, because it will open doors for a lot of other work that can happen and benefit your patients.
Great. Could you highlight a couple things? There's a question is, what is offered in a DPP? Like, what happens in the diabetes prevention program? What is the patient gaining from that maybe the nurse in the clinic or the clinic system doesn't have the capacity to provide?
Yeah, so it's largely a classroom-based program in the sense that the group is coming together with a trained lifestyle coach. They're going through a set curriculum every week for the first 16 weeks, and then meetings taper off into twice a month or once a month for the rest of the year. Those curriculum topics talk about a lot of things like how to set and manage SMART goals around your health, different aspects of what a healthy diet includes in a way that is sustainable and really gives ownership and buy-in to the person involved. We don't tell them what to eat and what not to eat, but we give a lot of information that helps them make choices that will, over time, incrementally build really lasting change for them into the routines that impact their likelihood of developing type 2 diabetes or continuing to be at risk for it. Physical activity, stress, sleep, healthy relationships, a lot of topics that relate to just someone's day-to-day life that you can talk about with your healthcare provider, but you're never going to have enough time with them over and over to dive deep into those aspects of your day-to-day life and how to make some of these small changes over time that lead to big long-term impacts on your health. The group dynamic is really important. It's a group-based program on purpose. It's really meant to build relationships between peers and with their coach. And then when it's done at the YMCA, we also have access to the YMCA and all of the physical activity options and social options that entails integrated into the program, so that that's something that supplements and enhances somebody's health behavior change journey.
A question about data and like, what system are you using to share data with the health delivery system? Or Lindsey, how are you able to see that it is a closed loop referral, that someone's going there, you're getting the information that they're attending? How does that communication work?
So the Y uses Weld Health. It's our EMR. It's really made for tracking both individual and cohort level data through programs like the DPP. So we have their health record. We know what's happening to them when they're on our watch. We also know why they were referred to us and what clinical information was sent to us in that referral. Epic, Cerner, NextGen, AthenaNet, many other EHRs can talk to Weld. And that's why we can get those referrals sent to us efficiently, because Weld meets the meaningful use standards that allows it to receive those data points from an EHR. Unfortunately, though, we can't talk back. We can't send information back. We do have some limited ability to send basically a PDF attachment back. And if the provider or the care team member chooses to open it, then they might be able to see updates on their patient. But in general, that's why we provide more aggregate level feedback on what happened to all the VMC patients that that year. During this project, it was on a much more frequent basis, giving that kind of update on how many were referred, how many enrolled. Of those enrolled, how many are, what's their retention, what's their weight loss, what's their physical activity look like? We would love to be able to do that in a more robust way as the technology itself offers more opportunities.
There was a quick comment, Lindsey, I'm curious, in the chat that was saying you have that video that you're talking about for advertisement and to educate your staff. Is that publicly available?
So I don't think so. Because we have made updates to the pathway since I think we've taken it off. But what I am going to put in the chat right now is a link to the most recent patient education video we created. This one is sort of an expansion of the work that we did previously, in that we decided we needed more than just the patient perspective. And so now we have a video that includes a provider who referred a patient to DPP, a lifestyle coach who did the DPP for the patient, and then the actual patient perspective. And it's all three of them kind of talking about the program. So I'm going to include that link to the YouTube video.
Great. There's a question in the chat too that's I think rather interesting, is we're seeing this more and more frequently in our nation, is obesity, adolescents, diabetes type 2 with adolescents. Is there any work being done on a program for at-risk adolescents, or is the DPP only for adults? They noticed on a health assessment completed by school nurses, there was 500 students identified as having type 2 diabetes in Washington State Public Schools. And I'm sure many more who have not been identified yet. So I was just curious if this is something that maybe the DPP program could focus on, or Lindsey, if there's a certain focus within that population within your work at all.
So I know this is part of why we're working so much to expand what we've done with the DPP work, because the DPP program does not address adolescents, but YMCA has other programs that do. And Sally, I'm sure you can speak more to that. So that's why we're looking at how do we expand doing better referrals to our community partner for these other populations.
Exactly. The DPP is for adults. The content and the choices that we talk about are adult focused, but the YMCA runs a program called Actively Changing Together, or ACT. It's a program we developed over 20 years ago with Seattle Children's Hospital. And we have worked with the State Department of Health this past year and the CDC to make it a CDC recognized family healthy weight program, of which a handful are recognized across the country. It's a 13-week program for youth in the 85th percentile of BMI for age or above and their families. And it is similar to DPP in the sense that you're meeting together as a group, you're going through a curriculum, talking about different behaviors of everyday life that you can make small changes to over time that are conducive to long-term disease prevention. And for young people, of course, we have very specific ways that we go about that. And so I'm happy to share more information outside of this call about the ACT program. It is for young people ages 8 to 14.
And then my last question is for you, Lindsey, is introducing a new workflow, a new process, a new thing for your staff to do can be really difficult. What is one tip that you have to increase the buy-in to get those people who might be like, oh, good, another task, another thing? Like, what is that thing that kind of got people brought into this work?
It comes up a lot when we're first starting the work, and that is really understanding what is current state and what is happening already. Just because we don't have a care pathway for it doesn't mean that people aren't already doing something for that disease process. So in this case, in prediabetes, even if you don't have a care pathway, if you have providers or staff working on this, they're doing something. So understanding what are they already doing and what's working well and what's not working well. And using a care pathway to address the barriers they're already facing will automatically create buy-in for you, because instead of saying, here's something else we want you to do, it's saying, here's something we know you're already doing, and here's how we want to make it easier or more efficient for you. Now that's going to kind of depend on what is already happening. And there have absolutely been situations in my experience where it's really hard to make it easier, but at least we can make some stronger guidance around it. And then the buy-in becomes, hey, we're already doing this with some providers. We need to get everybody on the same page. And sort of that, I want to call it community pressure of knowing that like this is the expected workflow also helps create that buy-in.
That's great. There's one more question that came in that I think is really interesting that I'm going to squeeze in and ask Sally. As you were building this relationship with UW Medicine, you were seeing this influx in referrals. I'm curious, how did that impact you at the Y and the capacity to provide the DPP program? Is there any tips you might have on the call for people who are also doing a DPP and trying to build relationships with the healthcare system to kind of navigate that?
Well, generated a lot more work. We've had to expand our referral management team. We've had to expand our coaching team. We're a community-based organization that does a lot. And so for any given body of work at the Y, there's not like extra money sitting around. So we have to expand as the demand expands. And that's what we've been able to do. Valley Medical Center certainly helped us generate a lot of that increased demand and make sure that we had our team set up for success. But yeah, I mean, referrals to lifestyle change programs like DPP are not typically a conversation like, here's the program, do you want to enroll? Great. They can be 20 minutes, an hour. People are talking about their real life and about why they've struggled with weight management and what they can eat and all these different things that are very real for them. So it's just a very time-consuming process. And, an organization receiving those referrals and trying to really talk to people and get them into programming needs to be prepared for the staff time that requires.
Thank you. That's all really helpful. This presentation has been immensely helpful. We're going to transition to the next phase of this webinar where we're going to have opportunities to connect with peers who are in attendance today. So in a moment, you will see that you'll have the opportunity to join a breakout room. Those will be opening here momentarily, and we invite you to join us and join a facilitated discussion with some peers about this work, about diabetes prevention, and how we can work on strengthening this within our area. So we'll open those rooms now. Welcome back, everybody. There was just a couple of remaining questions, so we wanted to ensure that we answered because they were such great questions. And so I'm going to invite Sally Sunder to come back forward and answer the question about not every place has access to a Y. Maybe not every place has access to a DPP program because they're more rural or they're more remote. How can those patients who may not be able to come into the clinic or leave their home or maybe too far out, still receive this type of care?
Yeah, so for the YMCA, we offer the program virtually and in person. I will say that, and that's statewide, I will say that we have much less in-person offerings since COVID, but even when we do, 9 out of 10 people prefer to participate virtually. In my opinion, it's because it's just breaks down barriers around transportation, childcare, a lot of the things that come in the way of doing such an intensive long-term intervention. And so I would just call out there that I think not being close to in-person programming is not a detractor for most people getting to participate. If they do live near a YMCA somewhere in Washington, we help them get access to their local YMCA during a portion of the program. And that's part of their program experience. If they don't, we have something called YMCA 360. It's a virtual platform that people can log into. It's what we call virtual YMCA membership. It has tons of pre-recorded and live fitness classes and family activities and other things that, again, supplement that person's health behavior change experience virtually if they're not able to do so in person. I also just want to be clear that the YMCA is not the only provider of the program. People have shared the link to the registry in the chat throughout this presentation. There are other organizations that provide DPP, and we are working with Imagine and the state and others to bring more of an infrastructure to how DPP can be easily accessible statewide to anyone, anywhere, by any provider of the program.
Thank you so much. I'm just looking at the time and we've come to the end of our event. You'll see my screen. If you could take a moment and let us know about your experience in the event, we just posted a link to our post survey. This post survey is also what you'll need to complete in order to or be able to access the next link to claim your CE credit. So I'll explain that in a moment here, but please work on that post survey. We really appreciate that feedback. It's very helpful for us. And then you can claim that CME credit. We want to invite you to attend any of our upcoming events. September 11th, we are having a webinar that's really focusing on the sustainability of health equity. And we have 4 different speakers representing CMS, a quality improvement organization, a health plan, and a health delivery system, all kind of talking from their lenses of how they're working to sustain health equity implementation within their work, but also within their organization and that culture of health equity. We'll have another learning lab in September. This one's more focused on perinatal behavioral health, specifically the Eat, Sleep, Console, and how organizations can be billing for that and implementing that practice within their organizations. And then if you have the opportunity to meet Steve Levy, he has been planning a wonderful conference that we are hosting October 15th through 16th. These events are all virtual, by the way, the Northwest Patient Safety Conference. So we encourage you and welcome anybody within your network to come and join us. If you do want to claim that CE credit, how you do that is you'll complete the post survey. When you complete your post survey and you hit submit, you'll get to this screen, which shows thank you that you submitted. You'll see that there is a blue hyperlink that's connected to the here. Click on that word here, and that will bring you to the CME claim form. You'll just complete that form, providing me with your information, and I will follow up with you in the upcoming weeks with a certificate that you joined us today. But we are so thankful for you to be joining us, and we're very thankful to our speakers for joining us. We will again send the recording and the PDF slides out to everybody, and I'll also send out Sally's contact information. She's gracefully added it in here, but she's a wonderful resource, and so is Lindsey. But we're hoping this can be expanded within our state, and we're just really grateful for each of you for joining us today. So thank you, everyone, and we hope you have a wonderful day.